Welcome to the deep dive. Today we're zeroing in on giant cell tumor of bone. We've got your revision notes right here, and the plan is simple. Pull out the absolute must-knows for your MSRA.
Exactly. High yield, focused. Let's get straight into it. What actually is a giant cell tumor, or GCT?
Okay, so GCT is a rare primary bone tumor. Think it starts in the bone. It's known for being locally aggressive.
Meaning it pushes boundaries, right? It doesn't necessarily spread far, but it's destructive where it is.
Precisely.
Right.
Especially in the long bones, often around the knee. That's a classic spot. Microscopically, you see these big multinucleated giant cells mixed in with mononuclear stromal cells. And a key point, it's generally benign, but that local aggressiveness means it can and often does recur.
Benign, but definitely not harmless locally. So what actually causes it? Do we know?
That's the thing, the exact cause. Still pretty much unknown. There's talk about genetic factors. Mutations in the H3F3A gene seem implicated.
Okay, H3F3A.
But importantly, it's not thought to be hereditary. It doesn't typically run in families.
Got it. So not inherited. Are there specific risk factors then, things that make it more likely?
Well, most cases just pop up sporadically, seemingly out of nowhere, with no clear risk factors you can point to.
Interesting.
But there are some associations noted with pre-existing bone conditions, things like Paget's disease or enchondromatosis.
Okay, so sometimes linked to other bone issues. Let's get into the mechanics, the pathophysiology. How does it actually damage the bone?
Right, you could sort of picture it like a rogue demolition crew inside the bone. It starts with these stromal cells growing abnormally.
The mononuclear ones you mentioned?
Yes. And these stromal cells, they release substances, signals, that basically call in and activate the osteoclast-like giant cells. These giant cells are the wrecking crew.
Ah, okay. So the stromal cells orchestrate the destruction carried out by the giant cells.
Exactly, leading to bone resorption, destruction. Why the stromal cells start proliferating abnormally in the first place, that's still a bit of a mystery researchers are working on.
A complex interaction. So if you suspect GCT, what else could it be? What are the main differential diagnoses?
Good question. It's important to rule out other things. A useful mnemonic could be OCAB.
OCAB. Okay, what's that stand for?
Osteosarcoma, that's a malignant one. Chondroblastoma, aneurysmal bone cyst, or ABC, and brown tumor of hyperparathyroidism.
Yeah, so quite a mix. How do you tell them apart?
It really takes a combination approach. Imaging, X-rays, CT, MRI is crucial. Then histopathology, actually looking at a biopsy sample under the microscope. And sometimes molecular testing, like checking for that H3F3A mutation, can help nail the diagnosis.
Makes sense. How common is GCT, statistically speaking?
In the UK, it accounts for roughly 5% of all primary bone tumors. So not super common, but significant enough.
And who tends to get it?
Typically youngish adults.
Yeah.
Think 20s to 40s is the peak age range.
Yeah.
And there's a slight tendency for it to affect females a bit more often than males.
Okay, 2040s, slightly more women. How would someone with GCT actually present? What symptoms bring them in?
Think PSP. Pain is usually the main one. Swelling over the affected bone area. And limited joint motion if it's near a joint like the knee.
PSP, pain, swelling, poor motion. Got it.
Yeah, and because the tumor weakens the bone, pathological fractures through the weakened area with minimal trauma are a definite risk. Very occasionally, it might just be picked up incidentally on an X-ray done for another reason.
Right. So presentation usually points towards the affected area. What investigations follow?
You'd start with imaging, definitely. Plain X-rays give you the first look. Then CT and MRI are really good for seeing the extent of the tumor, how much bone is involved, and if it's broken through the cortex.
And the biopsy.
Absolutely essential. You need that tissue diagnosis to confirm it's GCT, and sometimes to get an idea of its aggressiveness or grade. And as we mentioned, molecular testing for H3F3AA can sometimes add another layer of diagnostic certainty.
Okay, diagnosis sorted. How is GCT managed, particularly here in the UK?
Surgery is really the cornerstone of treatment. The most common approach is curettage.
Which is like scraping the tumor out.
Exactly. Scraping it out of the bone cavity. And usually surgeons use adjuvants, extra treatments in the cavity like bone cement, which provides support and also kills cells with heat, or sometimes cryotherapy, freezing the area to destroy any remaining tumor cells.
And if it's more extensive or keeps coming back?
Yeah, for those trickier cases or recurrent ones, more extensive surgery might be needed. That could mean en-bloc resection, taking out the whole tumor section of bone, potentially followed by reconstruction or even joint replacement if the joint is destroyed.
What about medications?
There is a targeted therapy called denosumab. It targets a pathway involved in osteoclast activation. It can be used sometimes before surgery to shrink the tumor, or maybe after surgery in certain situations, or for cases where surgery isn't possible.
Right, denosumab. Useful tool. What's the overall outlook, the prognosis?
It varies quite a bit depending on the tumor's location, size, the grade, how well it responds to treatment, but local recurrence is a known issue.
How common is recurrence?
The rates are often quoted around 20% to 40%. So follow-up is really important. And although it's rare, there is a small risk of malignant transformation, where the GCT turns into an outright sarcoma.
Okay, so recurrence is the main worry, plus that small chance of malignancy. What are the main complications overall, then?
Yeah, the big ones are local recurrence, as we said, pathological fractures if the bone is weakened, and impaired joint function, especially if it affects a major joint like the knee or hip. And again, that rare but serious possibility of malignant change. Okay, let's try and wrap that up. Key takeaways. JCT, rare, locally aggressive bone tumor, often near the knee. Giant cells plus stromal cells, cause unknown, but H3F3A link, not hereditary.
Risk factors. Mostly none, but sometimes Paget's or enchondromatosis. Pathophysiology is stromal cells activating giant demolition cells.
Differentials, remember OCAB, epidemiology.
Right.
About 5% of primary bone tumors, age 20-40s, slight female skew.
Presentation. Think PSP, pain, swelling, limited motion, plus fracture risk. Investigations, imaging, crucial biopsy, maybe molecular tests.
Management, usually a surgery, curettage plus savigins, sometimes denosumab. Prognosis recurrence in 20-40%. Rare malignant change. Complications follow from that.
Nicely summarized. You know, understanding that interplay between the stromal cells and the giant cells really highlights how complex bone remodeling is, doesn't it? It makes you wonder what other processes in the body, seemingly benign, could hold that kind of destructive potential if things go slightly wrong. Something to think about.
Definitely food for thought. For more resources and practice questions to nail your MSRA revision, do check out pastmsra.com and also freemsra.com. Thanks for joining us for this deep dive.